Hello, this is Jennifer, and this is my new podcast. It's called Medical Revolution in Progress. So I don't have a fancy intro yet or anything, but I hope you'll stick around to listen to some of the topics that I wanted to bring up I think are important. One of the reasons why I started to really not enjoy my job as much was when COVID hit. And I think that's the case for a lot of, medical providers, doctors, nurses, PAs, NPs, all these people that were my colleagues. When COVID hit, if you were already sort of emotionally drained, it only magnified it. On top of which, COVID was a political issue from the start. And that made things difficult because in order to practice medicine, I always consider first do no harm. And the way that I treated patients and thought about new medicines, vaccines, or anything else did not change when COVID started. But for some reason, any of the questions that I might have, any of the letters that I write to the Department of Public Health in the state I was in, really just caused more problems for me. So it was really a time where I did a lot of soul searching, and I still haven't really come out of that. And I don't believe that I'm the only person that experienced this in the medical field. So this podcast is really just about an insider's view of the medical system after working in it for more than 20 years. And I think, I'm going to highlight some things that I think are obviously a problem, tell some personal stories, and, discuss solutions too, because I don't think it's a good idea to just complain and criticize without offering solutions. So I'll try to do that as much as possible. But really, the other piece here is me discussing issues that I think as a patient, many people aren't aware of. And so it's really just me educating people who could potentially be patients or who are patients. I think a lot is unknown, and so I think it'd be helpful for me to do this. And I hope it is. So let's just start with one of the things that I think is kind of interesting. So in terms of accountability for hospitals and things like that, there's really medicine, like any other I guess scientific endeavor, is something that's difficult to change. We can just think about Galileo and what happened to him when he decided that the earth and the sun wasn't what everybody else thought it was. Now, that wasn't medicine, but through the years there have been medical people who are canceled. There's a ton of them that's been recently canceled, but even prior to COVID, there were a ton of people that got canceled. And often these people were canceled not because they were poor physicians or researchers, but because what they were saying was so different than what everyone else in the medical community thought that they were ostracized. I mean, this is just something we see in history and over again. So the brave people that speak up first generally have their heads cut off or ostracized or lose their job or their license and those kind of things, which makes them all the braver because they know that that's what's going to happen. Although sometimes they don't, fortunately. I don't think Andrew Wakefield knew what was going to hit him. Regardless, this is how medicine is. And so when you kind of beat to your own drum, it does make things difficult. Medicine used to be a lot different. When I first started, it was at the end of the era where, doctors still were able to have mom and pop shops. You could call your doctor. He was your only doctor. He'd been there for 20 years or 30 years, and he's treating all your parents and your family members, and he knows your name and all these things. I actually started my first year after graduation in a doctor's office like that. It was a father's son. Unfortunately, those are pretty much gone like your local pharmacy. They've been sucked up into managed care systems and hospitals. And this is where a lot of the trouble started. And, doctors lost their autonomy to practice to the point where, when you work in an emergency room, or if you even are a primary care doctor, part of a larger group, they will give you guidelines as to what's acceptable to prescribe for, say, strep throat or a urinary tract infection. And you have to follow those guidelines. Even obviously they're including opiates in there now too, ever since the OxyContin fiasco. Regardless, if you don't follow these guidelines, you will not reprimanded, but you'll get points taken off. And this goes towards your yearly review. So basically they're telling you, if this person has a sore throat, you have to swab their throat. You have to, if it's positive, then you have to prescribe penicillin at this dose for these many days. The next acceptable, if they're allergic, is X, Y, and Z. But I've worked in places like this. And so where does anything come in? I mean, a robot can do that, and honestly, I think they'll have robots doing that soon. But regardless, it takes away all the autonomy of the physician. Really, any clinical decision making and any experience that you may have with the patient or the condition they're presenting with. And so, that's how medicine is for every place I've worked in the past, I'd say 10 years. And it's really unfortunate. It takes a lot of the joy out of practicing. And then what do you have left? Well, the reason you went into medicine, because you want to help people, because you care for people, because you have, a skill set that allows you to go to a training program and acquire these skills. But the bottom line is you want to help people. And I loved helping people. Loved only because then what happens is you are told that you have quotas to meet. So just like a cop has to meet certain quotas, at the end of the month for speeding tickets, doctors and physician assistants and NPs and generally they have quotas to make every day. How many patients do they need to see? If it's an urgent care, it's 15-minute appointments. If you're lucky, your doctor schedules every 20-minute appointment. Now I'm talking about primary care, internal medicine, urgent care. I'm not talking about specialists. I don't know how they set up their schedules. But I'm talking about the majority of people that most people are going to see at some point. Emergency rooms, I'm not talking about those either. I'm sure there are quotas, but when I was there, I wasn't aware of what they were. So now, the medical provider comes in and they see a schedule, and if it's low, then it's going to be a problem for them come payment time. And it's also going to be a problem when they're, called in to talk to their office manager or administrator or whatever it is. I'm sure the higher up docs in the organization don't get the same sort of thing, but a lot of people get this sort of thing. And it's demoralizing. I don't care what anyone says. You can't see a patient, get a history, do an exam, diagnose the patient in 15-minute time slots. You cannot do it. That's why doctors are always late. If you want to know why, it's not because they want to make people upset. It's because they are fully booked 15-minute appointments or 20-minute appointments if you're lucky. And in 20 minutes, if someone comes in, no matter what it's for, you have to be finished so you can move on to the next patient. This creates a lot of stress. In addition, the notes that you have to complete and these sort of things. But that's beside the point. This is not humane. I understand there are much more inhumane ways of making a living. I'm not disputing that. But right now I'm just talking about medicine. And it's inhumane not only to the doctor to be put into that position, it's incredibly inhumane to the patient. Because you're on such a rush to make sure you stay on time so you can get out, at the end of the day before, say, 6 or 7, that immediately when you walk into the room, you're already, sort of concerned with how long this visit is going to be, instead of, I need to take care of this patient. Now, honestly, I got to the point where I stopped worrying about how long it would be. And I fell behind by an hour, 2 hours at times. And then some other people might have to take a patient. But my premise for a very long time was that I'm going to go in there and I'm going to talk to the patient, treat the patient. I don't care how long it takes me. This is what, this is what medicine is. But it's not the way that they allow it to happen anymore. So huge problem, huge burnout. And then the last place I worked was a health center, a community-based health center, a federally qualified, I think they call it FQHC, a federally qualified healthcare system. And if you don't know what these are healthcare systems that contract with the federal government so that they will see patients who have no insurance and patients who have state insurance, also known as Medicaid, not to be confused with Medicare, which is for people over the age of 65 or having a disability prior or at that age. So FQHC, the one that I worked at first I was really excited because after working in the emergency department, I thought, well, I'm going to miss this, because in the emergency department, because it was a level 1 trauma center, just saw everything you could possibly think of, was allowed to be part of the team treating these patients, which was such a privilege, and learned so much. I worked at the emergency department at Yale in New Haven, and that 7 years was an incredible experience for me. I wouldn't trade it for anything. I felt like I went through a residency. I'm a physician assistant, and so we can jump, between different specialties. But just the wealth of knowledge, the teamwork present, and it was a really good experience. So I enjoyed it, but after 7 years, I was burned out. And I give credit to anybody who, people do this for their entire careers. It's incredible. That being said, I didn't want to go to primary care. I knew it would be too slow. So urgent care. I go to this urgent care at an FQHC. And I was excited because their motto was, healthcare is a right, and they treated everyone. And most of their patient population was either not covered or had Medicaid. And so I just felt like I would be doing the right thing and being able to give back. And also I get something from it because I feel privileged to treat people like this, because I feel like I'm doing something worthy for humankind. I was very excited when I first started there, and after a couple of months I started to get a little bit suspicious, and then a little bit after that, I'd say a year into it, I was filled with contempt. And I'll just give a few little tidbits about it that really bothered me, and I think people might understand why. So because it's an FQHC, their whole, structure and their whole marketing is about how they're helping people who, would otherwise not be getting covered. What I found out, which is just sort of interesting, and it has to do with one of the other reasons why healthcare costs are absolutely insane in this country with no reason. Typically when a Medicaid patient is treated in a private practice, one of these hospital settings, or some of the doctors that still had the mom and pops, you don't get reimbursed very much. It depends on the state and how they do it. But in the state I was in, you'd get reimbursed maybe $50, $60. If it was a new visit, you might get $100. Yes, people have to make money, and doctors bill like this. Believe it or not, that's not a high fee for a typical visit. But we'll get into visits later. regardless, that's how much you would get paid. Well, I found out, I thought here these people are doing all this great stuff and they're so wonderful and they're nonprofit. That's not true. They First of all, I shouldn't say it's not true, but it sure seemed as if they were making quite a bit of profit and expanding with really unnecessary things, if you ask me. Regardless, they I found out they were contracted with the state I was in to make $168 per Medicaid visit. And that's not even a new patient. A new patient, I think, was $222. So even though like what 50-60% of their patients, which were thousands in the number, were Medicaid patients, they were not getting reimbursed $50 or $60 like primary care doctors do, the ones that don't want to take any Medicaid, and that's why. They were getting reimbursed almost double that, no matter what level visit it was. If it was a level 1, 2, 3, 4. So yeah, 4's, you had to be careful with anyway when you bill a level 4 visit in a doctor's office. But so once I understood that, I started to see, okay, well, I mean, sure, they get good for them, but that doesn't make any sense in terms of how you provide more care to patients, because they're only centered in one area. And yes, it has to be in a certain area, a low income area and that kind of thing, but it just shows how these things work. But what bothered me more than that, because that was just like, okay, that's how they run this, was the fear that was instilled in the patients that we had. I was urgent care, and so in the beginning of the day, if I only had 2 or 3 patients, by the end of the day, it would be filled up to 30 patients. And they would sometimes even double book, although I was not happy about the schedule to begin with. I signed up for it. The problem was this. They had nursing triage, but when you called the nurse as a new mother whose baby is 9-10 weeks, let's make the baby first trimester. The baby's 3 months, and the baby has a fever. Instead of the nurse asking the nurse triage questions, they immediately book them into an appointment. So that mother very well could either be at work, the baby's with her family or someone else, could be at home but has to take a bus to get to the center, or has to drive, doesn't have a car, can't get a bus, or takes an Uber. I mean, there's so many things that come into this when you're dealing with a lower income population. And so instead of offering the mother guidance onto what to do about the fever, asking questions, is the baby eating? Is the baby drinking? Is the fever steady? Is it going up? And offering suggestions as to do this, this, and this, and then, let us know if this happens. None of that is done. All that's done is you need to come into the doctor right away and need to see the doctor. And so I don't like that at all. I think that's really a poor way to treat patients and to practice medicine. It doesn't allow the nurses to use their wealth of knowledge and experience and skill set to help people. You might as well have a secretary doing that. Nothing is wrong with the secretary, but what I'm saying is it doesn't take any special medical training to schedule an appointment when a patient has any number of really harmless symptoms that can be managed at home. The entire population, at least where I worked, was treated this way. And I know why they did that. It's because they want to get the reimbursement for the visit. They want to get the $168 for that visit. But what bothered me was that, what about the patient? And what about the anxiety you're instilling in a patient? And the cost of getting the patient coming here? That's not so cheap for everybody. And I saw this over and over and over again. And it was just, that's the culture of it. And no matter how many times I tried, or a fellow or a colleague of mine tried, they didn't want to hear it. They don't want to hear it because it's going to cut in on their bottom line. So very frustrating. Um, and if you're a primary care doctor there, I was a PA, but if you're a primary care doctor, there's no difference. It's like that. That's why they have the urgent care. But if you're a primary care doctor and say you have a patient you've been treating for 10 years and they call up and they have X, Y, or Z that you can treat with this medicine, it's worked in the past, yada, yada, you're not allowed to do that there. They will not allow that. And so, again, the patient suffers and the doctor suffers. The doctor's hands are tied. He has no autonomy to treat someone as a human being with kindness and consideration and trying to help, not just the actual issue, but the whole patient's condition. And then, the patient is screwed because they have to come in. They know what they have. And even though they've seen you 20 times in the past 10 years for this same thing, they have to come in. That is absolutely terrible. And so I can't practice like that. And I don't know how anybody can. And I do know how people can, and I'm sorry. My resilience is not good enough to handle that. It's not okay. So those are just a couple of scenarios to start with. The other thing that they did, they had Suboxone treatment there. And they were trying so badly to get me and a colleague of mine to be, credentialed for it. It's some kind of test you have to take, and then you get the designation. I didn't want to do it. Why? Because Suboxone is not an easy medicine to prescribe. It's not, you can't just convert. If you convert it the wrong way, there can be a problem. Okay, people can overdose. And people who have opiate addiction need to be handled very skillfully. And I didn't feel like, even if I took this training, that I'm going to be comfortable prescribing this medication. Well, they just wanted us to do it. Why? Because they had a clinic there for Suboxone, and they had providers, and they had psychiatrists, and they had mental health therapists, and I'm all for all of that. But what I didn't like was the way it was really profit driven. Once again, they were always like putting people in the schedule over booking. I'm so glad I never got that certification. I feel so badly for those people that were going there for help. Not only would they put a ton of people in the schedule, they would get urines every time. And that's fine. Do a urine tox. Urine toxes can be expensive, though. When you send out that toxicology to get that report, those are not cheap. Even if you want to say it's $20 or $30 reimbursement for each one, if they're doing 40 patients a day and 20 urines, right? So what's that, $2,000 just from urine, just from urine, okay? And so okay, fine, like do the UTOX. A lot of treatment centers do UTOXes, and then that's part of the trust gaining and that sort of thing. But here was my issue. When the person came back positive for OxyContin or heroin or what have you, they would continue to prescribe the Suboxone. And they wouldn't do anything differently. And so that also bothers me, because I want people who have opiate addiction to get the right help more than, or as much as anyone. I've had friends pass away from opiate overdose. And so it's a real serious issue. And I don't like this kind of game where you've got to do a urine every day, and then no matter what it says, you continue to get your Suboxone. That's unethical to me. It's unethical. And then also trying to get other people to prescribe the Suboxone for new patients and things, when that's a tricky situation. So I don't think that that's ethical either. And so that's just one other issue I noticed while I was there. And I'm not going to go into more right now, but there's plenty more we can get into at some point. So just speaking of, healthcare costs, I think that, the healthcare prices in this country are ridiculous. And if you knew how they have to bill, it's insane. And it's complicated, and it's varying all over the place. I think a lot of people have already figured out if you use your insurance for medication, it's more expensive than if you actually pay for it cash at, say, Walmart or Target. Even with some procedures. So there's this website I found called Healthcare Blue Book, kind of like Kelly Blue Book for cars, but this is for healthcare procedures. And you can put in your zip code and whatever procedure it is that you may need to have, colonoscopy, a breast biopsy, whatever it may be. And they will tell you on this app what the fair value is and what's exorbitantly high. And they will break it down for you as to what the things are. And if there are any providers in your area that are agreeing to provide this for a fair value, then they will let you know about that as well. But it's a really interesting app. It's a really helpful app. And it shows you the insane amount of difference in some, like one radiology place may charge $2,200 for an MRI of your left knee or right knee. And then another place may charge $220. And so why is that? Why is that? That's a problem, right? I don't know where the balance lies in terms of what it should be reimbursed. But for it to be that wildly different, there's a problem, and that there's something that needs to be looked into. So the website is really good. You should check it out. And just to sort of give an idea of what you might find there. I ended up joining the app. They have an app on iPhone and probably Android. It's just Healthcare Blue Book, and it's free. So I'm just going to look up MRI, abdominal MRI, no contrast. So it says right off the bat, the price varies anywhere from $371 to $2,478. And they say that a fair price would be $687. Do you see the difference in the price, though? I'd love to know what accounts for that. Now, it's not showing me any facilities in my area that participate in this program, but I can go to, it says fair price information, and they detail how they get the fair price. And then they also have a price finder request, and so they offer you to help maybe find somebody to get a fair price one, and it may be further away from your home. But it's a really helpful website, and I think it's good for people to have this. And they'll even tell you if it's cheaper to get it with your insurance or pay for it cash and then submit it for a deductible. And then the last thing I want to talk about just for today was this website called Leapfrog. Leapfrog is a really interesting website. It's a way of grading hospitals, which takes away the slant, the bias, that you're typically going to find. The reason I found it is because I was listening to a podcast a couple years back, and they were talking about this really serious issue that was going on at the University of North Carolina's pediatric cardiac surgeons, and how in one day, 3 of the pediatric patients after cardiac surgery died. In a matter of a day or two, 3 of them died, and how devastating it was. And this had sparked apparently a much needed investigation that had been put off for quite some time. And so what they found was, a lot of the people that were performing these surgeries were not very well trained, and nobody wanted to speak up. They had developed a culture in which, mistakes weren't reviewed, criticisms weren't made, and there was no accountability of outcome. And this was what at one point was considered like a top cardiac pediatric surgery department. It turns out the New York Times did a big series on this, and it's devastating for these parents that lost their children at what they thought was a good hospital. Another hospital, Johns Hopkins Hospital, ended up having a similar issue. And they did a big revamping, and because of that New York Times article, people, there was some accountability made, and some of these departments closed down. But the reason I'm bringing this up is because if you're a patient and your child needs cardiac surgery, or your mother needs cardiac surgery, or somebody else needs, I don't know, some sort of operation on their spine, or whatever these things may be, how do you know if your hospital is good? How do you know if it's, well, it's UNC, they've been great for years, and then there's this whole secretive sort of cover over the fact that for the past several years the doctors are not doing well and the mortality rate's rising? How are you supposed to know that? That's scary, I thought to myself. And so that's what Leapfrog is. I mean, Leapfrog's free too. So I don't have any deals with these people. I just think it's important for people. And I tell everybody about this because I think it's helpful. So when you go on to Leapfrog, and I have a link for both of these things that I'm talking about today, the healthcare blue book, and then this Leapfrog, which is like a grading system. You can put in your zip code, and then it will give you a list of the hospitals in your area that complied with their requests. In addition, it will tell you any hospitals that denied giving them any information, which I think is very good to know. If the hospital doesn't want to let them know what their infectious disease rate is, or what their post-op number of items left in the patient is, and all these other things, or what their ratio is for nurses to patients in the ICU, if the hospital denies and doesn't want to let this group know that, well, I think that's important information, because that seems to me they're hiding something and probably don't want to go there. Fortunately, some people don't have as many options. If you only have 1 or 2 hospitals within a 100-mile radius, or one hospital, or maybe even further than that, you're not going to have much options. But for people who are in these big cities or major metropolitan areas, Boston, New York, really anywhere, you're going to find some really fascinating information. And so I highly recommend that you do that. So that's really my podcast for today. I hope that this has been helpful. I feel like I was all over the place, but I will be back with more information and some more sort of hidden, behind the scenes hospital doctor info. And I hope everybody enjoyed this, and peace out, guys.